All right, we're set to begin. Welcome so much to the Lunch, Learn, Link seminar, which is sponsored by the Sidney Kimmel Comprehensive Cancer Center and the Maryland Cigarette Restitution Fund Research Grant at Johns Hopkins. If any of you are not on our list, our mailing list for notifications about this seminar, do let us know. Give us your email and name, and we'll add you to the list. Nicole is standing here on the left side of the auditorium with tickets for pizza. So after the lecture in the gallery, we will have some pizza, iced tea, lemonade, and some salad. So I hope you can join us for that. So you need a ticket to get into line on that. So today we welcome Jessica Yeh, who is a member of the faculty both at the School of Medicine and the School of Public Health, and a member of the Welch Center. So she has broken the ground on diabetes and cancer and many of the lifestyle factors that are associated not only with cardiovascular disease, but also with cancer. So I'm looking forward to her talk today. Because she and Larry Apple, her colleague in primary prevention, designed a clinical trial that was carried out at the Cancer Center over a 2 to 3 year period, and they learned a lot about weight loss and some of the interventions in cancer survivors. So please welcome Jessica Yeh today.
Okay. Thank you so much, Norma, and good afternoon. Thank you for coming to my presentation today. So I was here actually a few years ago. I talked about obesity, diabetes, and cancer back then, and today I'm going to talk about intervention. So it's like a sequel to last presentation. Okay, so I see. Okay. So my presentation going to include like 3 parts. So I'm going to review some current evidence of lifestyle intervention in cancer survivors. And I will talk about this relatively new research infrastructure called CPEP Core, funded by Maryland Cigarette Restitution Fund as well as NCI's P30 grant. And I will show some preliminary data from SPIRIT trial, which was a trial we just completed a few months ago. So the number of cancer survivors has increased dramatically in the recent decades, and due to early screening, better diagnosis, and improved treatment. So based on the data from, I think it's a WHO-affiliated World Cancer Research Fund, the 5-year cancer survival increase, the percent of 5-year survival increase from about 50% in 1975 to almost 70% in 2019 to 2013. And as you can see here, there was no significant difference between men and women in terms of 5-year survivals. So as of January 2016, more than 15 million of cancer survivors in the US, representing 4.8% of the populations. And the cancer with high survival rates are breast, prostate, colorectal, endometrial, and melanomas. And that's why lifestyle interventions are usually implemented in those populations. So today I'm going to talk briefly about smoking cessation, and I'm going to discuss weight loss management, diet, and physical activity in cancer survivors. So smoking cessation is necessary. We all know that. And although all the health organizations recommended smoking cessation counseling should be provided to all cancer survivors as part of their routine survivorship care. But based on data from American Cancer Society survey, about 9 to 18% of survivors are still smoking, even after 9 years of cancer diagnosis. And most of the active smokers were were younger, and they've also found psychosocial factors such as stress are associated with smoking. And in addition to those active smokers, 16% of non-smoking cancer survivors are exposed to secondhand smoking based on data from NHANES. And there is a disparity with the highest prevalence of secondhand smoking exposure among Blacks and low-income populations. So smoking cessation is still, there's still a lot of work to be done for smoking cessations. While 10% to 10% of survivors are still smoking, most of the cancer survivors are overweight or obese. So based on this most up-to-date data from CDC, there are like 7 states with obesity prevalence more than 30. So in Maryland, we are the orange color here. So that's between 30% to 35% of obesity. And there is no state in the US as of 2017 has a prevalence lower than 20%. So what's the problem with obesity? So obesity being linked with several cancer sites. And World Cancer Research Fund reported strong evidence based on observational study link obesity to the following cancers. So include oral cancers, esophageal cancer with especially adenocarcinoma, stomach cancer, particularly in the cardiac region, pancreas cancer, gallbladder, liver, colorectal, postmenopausal breast, ovary, endometrial cancer, advanced prostate cancer, as well as kidney cancer. So as I mentioned, 70% of the breast and prostate cancer survivors are overweight or obese. And in addition to that, patients who are overweight or obese at the start of cancer therapy may gain additional weight as a complication for their treatment, such as chemotherapy for breast cancers. So the question is whether weight loss will improve cancer outcomes. So as shows, I'm going to review this slide, but as there are so many clinical trials ongoing on weight loss and cancer outcomes. If you just search clinicaltrial.gov, you will find hundreds of ongoing clinical trials. So American Society of Clinical Oncology has a statement back to 2015. It stated hundreds of small trials in patients with cancer evaluated feasibility and benefit of weight loss and physical activity intervention with regard to intermediate endpoints and patient-reported outcomes. But most of the trials focus on patients with early-stage breast cancers. And those trials have demonstrated that weight loss and physical activity intervention are feasible in cancer survivors, and they can lead to improvement in outcomes such as body composition, physical fitness, body image, fatigue, quality of life, and biomarkers linked to cancer outcomes. However, no data that provide definitive evidence that weight loss will prevent cancer or lower risk of a cancer-specific mortality. I'm not going to go through all the trials, and actually I'm going to talk about one of the weight loss trial we did. I just want to show one of the ongoing trial. It's a large clinical trial in breast cancer women. And they are going to randomize 3,000 breast cancer survivors with stage 2 to 3 breast cancers and diagnosed within 12 months. So it's early diagnosis of breast cancers. And the participant will be randomized to 2 arms. One is a control group, is a health education control, and another group will receive a 2-year supervised weight loss intervention. And if I recall it correctly, the intervention was done remotely through telephone and technologies. And I look forward to hearing the result in a few years from this study. So let me just switch the topic to dietary intervention. So the impact of dietary pattern upon prognosis in patients with cancer has been widely studied. And cohort studies already found adherence to a high-quality diet and healthy diet pattern was inversely associated with overall mortality among cancer survivors. So healthy diet can prevent cancer progression based on a lot of cohort study and meta-analysis. However, there is no consistent findings in randomized clinical trials. So for dietary intervention, there were 2 landmark studies, both in breast cancer survivors I'm going to talk about. So the first one, many of you probably know this already. So the first one was a Women's Healthy Eating and Living WHEL trial. And in that trial, they randomized 3,000 breast cancer survivors, and the intervention was a diet very high in vegetable, fruit, and fiber, and low in fat. So they followed the participant for many years, and they found the intervention group achieved increased servings of vegetables, fruit, and fiber, and decreased their energy intake from fat significantly. And they did not find any weight loss in this population. However, when they look at the survival outcome, there was no effect from such a type of dietary intervention. So around the same time, another big trial called WHEL, Women's Intervention Nutrition Study, was also conducted. And this trial focused on dietary fat reduction as an intervention. So in the end of the trial, they found the dietary fat intake was lower in the intervention group than in the control, significantly lower. And they did see some weight loss, moderate weight loss, 2.7 kilograms in the intervention group. Different from the previous trial, they did find some beneficial effect from low-fat diet in this trial with a p-value 0.03, so lower, higher survival rate. Is that right? I'm sorry. It's a percent with relapse-free survival event. This is in the control group and in the dietary intervention group. Just want to talk about, so dietary intervention trial, there are not a lot in other type of cancer patients. So this was one of the trial conducted in prostate cancer survivors, only include 93 men with early stage prostate cancers in active surveillance. And the intervention was to encourage men to adopt a low-fat, plant-based, and to exercise and practice stress management, and to attempt group support sessions. And at 1 year, they found PSA decreased by 4% in the intervention group, but increased by 6% in the control group. And that was statistically significant. At 2 years, they found 5% of men in the intervention group versus 27% of control had undergone conventional prostate cancer treatment. So the result of this trial was very encouraging. An ongoing trial is called WHEL, which is a larger trial, going to randomize 478 men in 91 study sites. So one lesson we learned from our intervention study in cancer patients is it's pretty difficult to recruit men into the trial. So this in the WHEL study, they are going to use a telephone-based intervention, and the intervention focus on high vegetable diet counseling to prevent progression in patients with prostate cancer on active surveillance. And their outcome will be clinical progression defined by PSA and the pathology findings. So we will, we'll hear about the result in a few years. Physical activity. So we know based on observational study, we know there was a link between exercise and reduction in cancer mortality and overall mortality in early stage breast, prostate, and colorectal cancers. But most of the RCTs on physical activities found a lot of RCT in physical activities found effect from exercise to improve health-related quality of life and to reduce fatigue. But for physical activities, there are several barriers. So first is complications after cancer therapy. So for example, permanent neurological damage after colon cancer treatment that would prevent patient from doing exercise. And another reason is actually we lack of guideline for recommendation. We don't actually know what to tell our patient, how much to exercise and what to do, how often. Two ongoing trial I want to mention using physical activities. So the first one is called interval trial for advanced prostate cancer patients. So they are going to randomize more than 800 men in multiple countries. And the intervention is a high intensity aerobic and resistant training started with supervised exercise and tapering to self-management with psychosocial support. And the control group is psychosocial support only. And the primary outcome is overall survival. That's why they need a big sample size to start with. Another trial ongoing is called Challenge trial. It's in colon cancer survivors. So they are going to randomize 962 participants, and they are survivors of high-risk stage 2 or 3 colon cancer who complete adjuvant therapies. And the intervention will include behavioral support program and supervised exercise session over 3 years. So it's a long period of interventions. And again, the primary outcome is disease-free survival. So the current trial already go beyond the previous trial looking at biomarker only, but that means trying to link biomarker to clinical outcomes. But that also means we need a bigger sample size and longer period of follow-up. So just to summarize what are the research gap based on the literature. So whether purposeful weight loss after cancer diagnosis can improve outcome is still unknown, and is a topic of continued investigations. And there are very few randomized trials testing the impact of dietary change on cancer outcomes. And there are no data from RCTs to date testing the impact of increased physical activity on rate of cancer recurrence or mortality. So to fill in those research gaps and to promote healthy lifestyles in our local populations. So I'm going to talk about this new infrastructure funded by Maryland Cigarette Restitution Fund and the National Cancer Institute through the P30 mechanism. It's called Community-Based Participant Engagement and Translation Core. And it is a developing core to facilitate intervention studies. So what does the core do? So there are like three main services we provide. So first is to provide consultation on community-based intervention studies with focus on promoting minority recruitment into cancer-related studies. And we also provide consultation on lifestyle intervention, for example, implementation of behavioral and lifestyle studies. And we also train investigative team on protocol development and data collection procedures. So the CPEP core is based on ProHealth, which is an off-campus facility in West Baltimore, about 7 miles from here. We offer free parking in ProHealth, which is convenient and an advantage for lifestyle intervention, especially for study participants. So here are some pictures. So this is the front of the ProHealth. It used to be a motel like 30 years ago. But now we have a meeting space here, not meeting space, reception space in the front. We also have examination rooms. We also have labs to process blood, and we have a refrigerator to store blood samples. Here we'll have an exercise room for intervention study, and there is a metabolic kitchens for feeding studies. So ProHealth, and lately we developed computerized biobanking system using open specimen framework, and it's been very convenient. So the ProHealth was established by Dr. Paul Whelton about 25 years ago, and the original goal was for cardiovascular-related outcome studies. So there were a lot of landmark studies being conducted at ProHealth. So if you ever heard about DASH diet, the #1 diet in the U.S., that was done at ProHealth. And we also have several weight loss trial, weight loss maintenance, power trial, look-ahead trial for type 2 diabetes, pharmaco blood pressure control trials, vitamin trials, as well as observational epidemiology studies. And currently, I just want to show some sample about what we are doing at ProHealth other than cancer study. So there are like 3 clinical trials of CVD risk reduction in people with severe mental illness, study trial using vitamin D to prevent fall in older adults, and look ahead trial continuation using lifestyle weight loss trial in people with diabetes, look at the mortality as well as cognitive function as outcomes. TRIM is a time-restricted feeding on weight funded by American Heart Association. 5+ nuts and beans for kidney. Apparently, it's a dietary intervention for chronic kidney disease, as well as DIGO, which is a feeding study in patients with gout. But CPEP core is actively involved in cancer studies. So for example, the Power to Breast Cancer Survivors was conducted by PI was Dr. Vera Stern. They use it's a weight loss program in breast cancer survivors. Empower is a new cancer trial will start. Next year. PI is Dr. Corey Josh Yu, and it's a weight loss trial in men with more advanced prostate cancers. PASS, promoting physical activity through Alexa. It's a collaboration with Amazon. Spirit, I'm going to talk about that after this. And Spirit Microbiome is a funded ancillary study. PI is Dr. Noel Mueller. We collect a stool sample from the trial. So we are going to look at gut microbiomes. TAM trial, we just submitted with the other 13 clinical sites, going to look at using metformin for agent outcomes. So if any of you are interested in using our facility in ProHealth, I'll be happy to talk, to discuss. The future direction for CPAP core is actually going to build on our past experience and success in cardiovascular disease, and to extend our infrastructure to community-based cancer prevention and controls. We want to establish infrastructure to conduct lifestyle intervention in elderly population. We do have a lot of experience on intervention in older adults. We also want to establish expertise in microbiome study because take advantage of a funded trial, expand collaboration partnership with local community for recruitment and dissemination, collaborate with the healthcare system, and collaborate with industry to disseminate science. So one example was we are taking our weight loss trial result and the platform and partnership with a commercial company. We are going to develop like web-based intervention, not only for diabetes prevention, but hopefully also can be used in other population. Okay. So I'm going to talk about SPIRIT trial. So for the rest of my presentation, so it's a trial of behavioral weight loss and metformin treatment to lower insulin growth factor in cancer survivors. And I'm the PI for the trial, and Dr. Larry Apple and Mike Cartucci in Oncology Center are my co-PIs. And the trial was funded by CRF as well as internal funding from the Oncology Center. So insulin growth factor 1, IGF-1, is a protein produced by liver that contributes to cell growth. So higher IGF-1 has been associated with a higher incidence of some cancer and survival in cancer patients. So that means maybe reducing IGF might prevent cancer in patients without cancer or in cancer recurrence in cancer survivors. So how about weight and IGF? Actually, the association between weight loss and IGF-1 is not entirely clear. So some cross-sectional study reported a reverse U-shape kind of associations. And RCTs show high physical activity level associated with lower IGF level in breast cancer survivors. And other studies show reduction in caloric intake with with substantial weight loss, also lower IGF-1 level. Another intervention we use is metformin. So metformin is the first line medication prescribed to treat early type 2 diabetes. And it's been around for decades, like 30, 50 years. And metformin will lower glucose by inhibiting glucose production in the liver. But other studies also show like metformin decrease IGF-1 and other growth factor in preclinical and small, very short-term, couple weeks, couple months in human study. So in our trial, we want to conduct this is a 3-arm trial to compare the effect of self-directed weight loss, which is a comparison group, coach-directed weight loss, and metformin treatment on IGF-1 and IGF-1 to IGF-BP3 ratio. So this is my investigative team, including investigator from oncology center, from medicine, primary care doctors, and lab researcher as well. That's our group picture in front of ProHealth. The study populations for our trial, we recruit participants as cancer survivors, defined as person who self-report a malignant solid tumor diagnosis and have completed the curative intent treatment and have no ongoing or planned active treatment, including surgery, radiation therapy, or other chemo treatment other than chemophylaxis. So where did we recruit our participants? So we implemented several strategies simultaneously. But the first two are our main strategy. So first, back then, about 3 years ago now. So we obtained list of commercial available list of cancer survivors. So that means actually we kind of contract out to a mail house, and we did not receive any cancer survivors' name or address, nothing. But I don't exactly know how they know which house may have cancer survivors, but they mail out, actually we mail out more than 20,000 invitations, so it's like a mass mailing through these mailing house companies. And we also did advertisement in several local newspapers. And we also run an online advertisement through Facebook. We also put a brochure in physician's office. And of course, direct referral from our colleagues in oncology center, as well as actually primary care, and word of mouth from other participants. And we also attend a health fair, like a senior expo or Baltimore County Fair. So all the enrollment and data collection were conducted at ProHealth in Woodlawn. So this diagram shows the recruitment. So we randomized 121 participants in the end, but before that we spoke to 406 of them before the screening. So 10 of people we contact us through the health fair, 52 from word of mouth, 84 from advertisement, like in the newspaper, 24 from online advertisement, and majority, 220 from brochure, mass mailing brochure, and others is 14. So the mass mailing produced about 1% response rate, which is consistent with our other previous studies. So here is the study design, randomized 121 to 3 groups. A comparison group, coach-directed behavioral weight loss or metformin. So for the coach-directed behavioral weight loss, we use a platform called Energy, and it's delivered by coach through web and phone. And the protocol of this delivery intervention was published in 2011 with a power trial. And data collection took place in 4-time period: baseline, 3 months, 6 months, and 12 months. So here is just some screenshot of the weight loss intervention website. So people can share their data with their coach through the website, so they look at the same thing at the same time. So about the initial weight and what's the documentation about activities. Here is to track food, weight, and physical activities. And more about what's your weight, food, and activity. Just show some screenshot. It's been very nice, very convenient to use. We did set the goal for behavioral intervention. We have a weight loss goal with minimum 5% weight loss. It's individually tailored. caloric intake recommendation was based on their weight. We have a dietary recommendation pretty much based on DASH diet, and we also set a physical activity goal as more than 180 minutes per week. In terms of metformin, we did obtain an IND waiver from FDA for the trial. And we titrate metformin use, start with 5 milligram once per day, and titrate up to 2,000 milligram per day. And in our trial, as long as actually most of our participants titrate were able to tolerate 2,000 milligram per day. The outcome I mentioned, the primary outcome is IGF, and we also look at other outcomes like BMI, glucose, insulin, A1C, blood pressure, lipid diet, physical activity, quality of life, and inflammation markers. Yes, we still have stored blood samples. If you are interested in certain topic, I'll be happy to discuss. Okay, this one is our diagrams. So I cut off from the upper part to save space, but we randomized 121 participants to 3 groups. I just want to show, so one group in coach-directed is 39, start with 39, 42 in metformin, 40 in the comparison group. And our primary outcome is 6 months follow-up. We have 38 out of 39 have a lab measure, 40 out of 42 with lab measure in the metformin group, and 40 out of 40 in the control group. So we have very few missing data. I'm grateful for all the work the staff and the research team being able to obtain. In 12 months, we also maintain a very good response rate. So few missing data in our data set. So just show some baseline characteristic for our trial. So mean age is around 60. And as I mentioned, it's very difficult to recruit men. So we have 80% of female participants. But we were very, very successful in terms of minority recruitment with more than 45%, about 45% as Black. The weight at baseline is, BMI at baseline is 35, and they have several medical conditions. So 1/3 of a participant has a hypertension, and about 20% has arthritis. And because they were required, they cannot take any metformin, so we did not have a lot of diabetes patients. Those 2 were allowed to be in trial because they were not taking metformin at all. Pre-diabetes and high cholesterol is about 15%. In terms of type of cancer they have, so majority of participants were having history of breast cancer, and the rest of the cancer type were a smaller population, and 90% of them have only one cancer, and some of them has more than one cancer. Okay, I'm going to show you some results just to orient you guys. This is the weight change in over time, so 0, 3, 6, 9, and 12 months. And the blue line is the weight pattern in the comparison group. So they lost a little bit weight initially, just like other trial participants. They were enthusiastic about participation, so there was placebo effect even you are in a control group. So this one is the coach-directed behavioral weight loss. It's expected there was a significant maximum weight loss obtained at 6 months. It's consistent with other weight loss literature, and regain some weight in 12 months. So this one is a metformin group. So they also lost weight significantly, and we were somewhat surprised about the amount of weight they were able to lose at 12 months. It's pretty much no difference with the the coach-directed group. And compared to the comparison group, both group has significant weight loss as compared to the comparison group. So this is just waterfall plot for the weight change. As we can see here, most of our participants has certain type of weight loss, and of some degree of weight loss. Of course, some of them gain weight over the period. This shows 6 months. And here is 5% weight loss. So all of those participants achieve the weight loss goal of 5%. And here is 10%. So some of them lost more than 10% of weight over 6 months. And this one just show the same, just show 12 months of weight change. And as you can see here, more at 12 months, more participants gain weight, especially in the comparison group. Here shows insulin. I presented as a percent change because the data were somewhat skewed. And insulin change is consistent with the weight loss pattern, with some changes in some decrease in the comparison group, but significant decrease in the weight loss in the behavioral weight loss group at 6 months and regain back. And the metformin group is just consistent with the weight loss pattern. They continue to decrease over 12 months period. Okay, here comes IGF. Okay, so this is I don't know if we are surprised or not surprised. Anyway, there was no change in the comparison group and no significant change in the weight loss group. So what we found is weight loss and IGF probably not really related. But in the metformin group, we saw significant decrease in metformin group at 3 months and regain a little bit at 6 months, but still compared to the comparison group are significant and regain back 12 months. And this is IGF-1 to IGF-3 ratio, and it's similar to the previous slide. So we are in the middle of sorting out what's going on here and look at the adherence data as well as weight loss data to see what can explain the observation in the metformin group. But this is good. We kind of like prove metformin may be beneficial. It's possibly only short term, but in the previous studies, no study really went beyond 3 months or 3 or 4 months for metformin intervention. So we have 2 ancillary studies. So I mentioned about microbiome study, and it's funded ancillary study funded by a K award as well as a CRF grant. So we are in the process of looking at the microbiome data. And we also did a comparative effectiveness study of recruiting trial participants using online advertisement, and we already published this paper this year in clinical trials. So we did a partnership with investigator from Carey Business School, and we cost out the cost to randomize 1 patient. What's the cost using mass mailing, using Facebook? That if you are interested, this is the reference. It's pretty expensive to recruit a participant from website, although it sounds like a great idea, but probably not in this population. Anyway, okay, so I do not have a conclusion slide for SPIRIT trial because we are still sorting out our data, and I don't know what to conclude at this moment. But I want to conclude my presentation with two slides with recommendations. So the first slide of recommendations from American Cancer Society about lifestyles. So they advise cancer survivors to maintain a healthy weight and attempt weight loss if overweight or obese. to consume a healthy diet with at least 5 servings of fruit and vegetable per day and limited injection of processed food or red meat. And limit alcohol to no more than 1 drink per day for women and 2 drinks per day for men. So I didn't talk about alcohol. Alcohol is more controversial topic. It's different. It can be, some studies show some beneficial effect for CVD, but harmful effect for cancer. So, and I didn't have time to talk about that. And I also want to share this slide from American College of Sports Medicine. I kind of like it. They advise cancer survivor to exercise, about exercise training is safe during and after cancer treatment and result in improvement in physical functioning, quality of life, and cancer-related fatigue in several cancer survivor groups. Some of you may think those are like weak, soft outcomes, but for cancer survivors, a lot of time they are really important, maybe even more important than mortality. And this guideline also acknowledge the implication for disease outcome and survival are still unknown. But what I like is the advice to avoid inactivity, even in cancer patients with existing disease or undergoing difficult treatment, is likely helpful. So that's my presentation, and thank you for your attention. I'll be happy to take questions.
Thank you so much, Jessica. It was a whirlwind tour of all that's going on right now. Questions from the audience? The microphone over. We're using this so that you can be heard on the recording.
Thank you so much for that presentation. I'm a GYN oncology fellow over at the hospital, and I had a question about the use of metformin and whether or not, forgive me if I missed it, whether or not you're studying actual cancer outcomes in terms of progression or survival, or plan to do that in the studies with metformin. The reason I ask is because at least in endometrial cancer, we're testing metformin as an anti-cancer drug because it's an mTOR inhibitor, so that could potentially influence your results in a lifestyle study.
Okay, so so it's great to hear about the ongoing trial in endometrial cancer. Yes, so when we plan for the trial, we start with lifestyle intervention, right? So the idea was to promote healthy lifestyle in cancer survivor, and also maybe that will be beneficial for cardiovascular outcomes. And metformin was like added later, but we did see a lot of evidence on the beneficial effect based on small trials on cancer progression. But in our study, unfortunately, we were not able to obtain like a tissue marker or other things to say clinically this is helpful. So all we can do is to look at biomarker as surrogate as a progression. But I'll be interested to hear more about your study. Thank you.
I had a question about the WHEL study that you mentioned at the beginning.
Okay.
Whether it was going to be carried out through telephone. And I was just wondering if in those kind of studies is follow-up and like data analysis, is it like more complicated?
In terms of like a deliver lifestyle over the telephone? Yeah, that's a great question. So okay, couple ways people are doing. So deliver over the phone is not that difficult, as long as you can work out the schedules and your intervention team. So for example, in one of the trial called the new ongoing trial in the large the breast cancer survivor, BWEL, they are supposed to randomize more than 3,000 women. And one of the, I heard that this from their presentations, one of their challenge is working out the time zone difference. So their call center interventionists were in the East Coast. So when they are working, they cannot accommodate the participant in the West Coast. So they have to work out a schedule, or they have to collaborate with other people in the West Coast to deliver the intervention. But like in Spirit trial, one of my interventionists is based on Colorado. So it's not that difficult in terms of deliver intervention over the phone. However, if we are going to use like a website or technology, then that's another layer of eligibility. So like in Spirit trial, we actually has to give a small, quick test for potential participant to make sure they know how to receive email, how to check websites. It's like just like an on-site test a little bit. So that's another like a challenge you have to go through in the remote analysis. In terms of data collection, in Spirit trial, we asked people to come to ProHealth. So that was because that was done locally. But in those multi-nation or multi-site study, a lot of them has to contract out like a local vendor in their area for participants to go to, say, somewhere to get the blood draw, or they send people to their house to obtain data. So those can be done, and it's more frequent now, especially if we want to collect data from more generalizable population, like if we want to collect data from people in the rural area or in somewhere else. Those are the considerations, has to be taken account into. Good question. That's a long answer, sorry.
So, Jessica, a question about the recommendations. So I was so glad to see that as your last slide. But a number of our providers probably aren't attuned to looking at the College of Sports Medicine guidelines. Do you have suggestions about how we might incorporate a recommendation to exercise, even at a low level for cancer patients in the oncology community?
Sure. So American College of Sports Medicine, I would have missed this guideline if they did not make this guideline with American Cancer Society. So they kind of have a joint program to make a recommendation. So that was good. I think we do want to maybe develop better research incorporating physical activity. So physical activity, it can be mild or moderate. So like walking can be a great type interventions to start with, but it's only as long as the participant is able to walk, right? But physical activity should be also tailored to different type of patient. So for example, breast cancer patient, if they have a lateral mastectomy, then they cannot move their arms. So maybe like physical training or lifting may not be the best type of physical exercise we want to recommend. I think it depends.
Claire, I see you in the audience. Is there, do you have thoughts about this in your work with survivors?
Well, I just wanted to congratulate Jessica on this entire body of work. It seems like a long time ago we started with that systematic review of diabetes and cancer, but I think she's both highlighted the importance and relative contributions of diet, physical activity, and weight to cancer survivors, as well as doing the cutting edge research looking at these interventions as well as the metformin. So I'm excited to see it continue to progress.
Thank you so much, Claire. Yeah, this was so we started with a bunch of systematic review, successful systematic review and meta-analysis looking at the diabetes and cancer survivals about 10 years ago. But after that, I had the opportunity to move forward with intervention in this population. So I think the combination of training from school public health and experience from school medicine really contribute to this area of research.
Yes. Okay, we'll adjourn for today. Do join us at the gallery. Look for Nicole outside for your ticket for pizza. And join me in thanking Jessica for coming.
Thank you.